Wonderful introduction, Dr. Kinney. It is a true pleasure to talk to you guys this morning. Let me just get my presentation going, and right, so this should work. So it's a true pleasure to be here this morning. As many of you might know, I am a Bangalore boy. I did my schooling, I went to my 11th and 12th, and then I left Bangalore to go to JIPMA to do my medical schooling. Although I must say I've been here now for about 20 years now. But it is a great pleasure to be here well, for me, it's the morning. For you guys, it's the evening. So thank you again to the organizers for this invitation. So what I thought I'd do is talk a little bit about hepatic neoplasms. And I said, in my title that I gave you guys, I said top 4 challenges. I've now made it 5. We'll see how many we can get through in half an hour. So this, you look at this image here, and if you're a trainee, you should be able to recognize this as a hepatocellular carcinoma. This isn't a huge challenge for the diagnosis, isn't it? It's got this massive macrotrabecular pattern. But if you were my trainee, I would expect you to ask me this question. And the question would be, why in the world do you think this is an HCC? Now, this is an HCC because the cells look like hepatocytes, 1. And 2, and this is really important, notice that endothelial wrapping there. There's endothelial cells on that side. There's endothelial cells on that side. This is referred to as endothelial cell wrapping. And this allows me to do 2 things. 1, sorry, there's some disturbance in the background. Apologize. 2 things. 1, I can recognize this as a trabecular pattern, which is a unique feature of hepatocellular carcinomas, quite a unique feature. 2, it allows me to count the thickness of these plates, and the thicker the plates, the more likely you are that this is HCC. So this, just based on the thickness of those plates, is HCC. But that's not the only pattern you see in HCC. Often you'll see this sort of glandular or pseudoglandular pattern, not to be mistaken for adenocarcinoma. These cells truly look like hepatocytes. And then, in fact, if you look at your HCCs, you'll tend to see a lot of heterogeneity even within the same tumor. And occasionally you'll see these very solid looking sheets of cells where you do not see that trabecular architecture. Over the years, and I've been doing this a little over 20 years now, there are certain patterns that are very challenging. At least I find them fairly challenging when making a diagnosis of HCC. And one of those challenging patterns is this, which is the steatohepatitic pattern. And oddly enough, we see an increasing number of HCCs with this pattern. Now you look at this and you look at the balloon cells and you look at the Mallory-Hyland, and it is so easy for you to look at this and say, this is steatohepatitis, this is benign liver. But this is not benign liver because there are no portal tracts here. But remember this variant because you might dismiss this as benign steatohepatitic liver. This is the only example of this entity I've ever seen. This is referred to as a myxoid pattern HCC. So notice all this myxoid stuff in the background. The third variant that often trips me up is this so-called Scaris HCC, lots of fibrosis. If you think back at all of the HCCs you've seen over the years, you typically do not see a lot of fibrosis. So Scaris HCCs have a tremendous amount of fibrosis. In fact, when you see fibrosis, you should be thinking of a cholangiocarcinoma and not an HCC. Now, you need to distinguish that Scaris carcinoma from fibrolamellar carcinomas. And the way you do that is that these fibrolamellar carcinomas have a lot more cytoplasm, lots of granular eosinophilic cytoplasm. And the fibrosis tends to have this sort of lamella, these parallel collagen bundles, this lamellar architecture. And most fibrolamellar carcinomas have this sort of pseudoglandular pattern. Now, in the ideal world, you'd like to confirm your diagnosis of fibrolamellar carcinomas. You know that they occur in non-cirrhotic livers, they occur in the lung, but you really do want to find some means of confirming your diagnosis. And one useful stain is the combined presence of CD68 and 7 is very unusual in a conventional HCC and would suggest a fibrolamellar carcinoma. But I think increasingly, as you guys have probably noticed, given the fact that there's targeted therapies that are quickly emerging for fibrolamellar carcinoma, I think we'll all be forced to molecularly confirm some of these diagnoses. Not today, but perhaps a couple of years down the line. So as I promised you, I'm going to do a sort of a problem-based approach, right? So let's see, I may perhaps get through 4, I might even get through 5 problems if I'm lucky. So problem number 1 is probably the easiest of them. Did the radiologist miss the lesion? And you know, I hope there are no radiologists in the audience, but the radiologist, regardless of where they put their needle in, will swear up and down the corridors to you that the needle was in the lesion, they were smack in the middle of it, there's no way they missed it. But believe you me, they missed the lesion, they do miss the lesion. And so my very first step that I take is to make sure that the biopsy from a mass-forming lesion in the liver is indeed representative of the lesion. And that, you know, for trainees, I think that this is particularly for trainees, this is fairly easy to do because all you have to do is to look for portal tracts. You look for that bile duct, that vein, that arteriole. But when the biopsy gets very fragmented, and this is not uncommon, you'll get little bits of tissue all fragmented all over the place. Either that, or if you're feeling terribly lazy, right? So a glutamine synthetase stain makes your life somewhat easier. Or if you're feeling very rich and wealthy and you have the money to throw on a stain, I find the glutamine synthetase stain very helpful. This is what glutamine synthetase does, right? So it stains those hepatocytes immediately around the central vein. So when you look at this on very low power, you can quickly pick out the central veins, the portal tracts, and it allows you to define normal liver. Now, you don't absolutely need the stain, but like I said, if the biopsy is fragmented, I particularly find it very, very helpful. So you can pick your portal tracts and your central veins, and you'll know it's normal liver. All right, so that is step number 1. So step number 2 is this problem. You look down the microscope, you've confirmed it's lesional, the cells look like hepatocytes. The question is it benign hepatocytes or are these malignant hepatocytes? Is this an hepatocellular carcinoma? And what you're really trying to do here is to distinguish benign liver from a very well-differentiated HCC. And believe me, this is one of those very tough calls. And I'll do my best to give you my take on the subject. So as you probably have noticed, I am aging. I can't remember as many things as I used to remember in my younger years, so I carry very limited cheat sheets in my head. This is the cheat sheet, so take a photograph of this if you wanna. This is the cheat sheet I carry to distinguish between benign and malignant. There are 3 histologic features, 2 histochemical features, and 2 antibodies, although I use only 1 antibody. So let's look at each one of these features. All right, for the trainees in the audience, these look like hepatocytes, right? Polygonal cells, abundant eosinophilic cytoplasm, but is this malignant or is this benign? And here's how I do it for this particular image, right? There are endothelial cells there, so there's endothelial wrapping. There's endothelial cells here, there's endothelial wrapping. That allows me to count the plates. This is way more than 4 cell thick. This is HCC to me, period, regardless of what the underlying atypia is, right? So thickened plates, you can take that to the bank with you. So I am a board-certified cytopathologist, but I'm not a great fan, and listen to me carefully here, I am not a great fan of making a diagnosis of a well-differentiated HCC on smears. But if you can make a cell block preparation, that's a completely different ballgame. So notice that cell block, endothelial wrapping, that plate is more than 4 cell thick. That's HCC until proven otherwise. And there's a bonus there. There's a mitotic figure. It's unusual to see mitotic figures in benign liver. This criterion is somewhat more challenging, right? So I'm talking of increased cellularity. Now, I took these at roughly the same magnification, and you'll see that the malignant liver looks more cellular. And the reason why it looks more cellular is not that the nuclei have gotten any bigger. It's the cytoplasm that has shrunk and become more amphiphilic, giving you that bluish appearance. That monotonous cellular appearance is very helpful in my book for diagnosing a very well-differentiated HCC. Good old reticulin stain, believe me, it still works after all these years. Loss of reticulin is near diagnostic of HCC. One important caveat to remember, and that is you can have an artifactual loss of reticulin in a very fatty liver. So if you've got a lot of fat around, beware, your reticulin may be artifactually lost. There's two stains, HFCP70 and Glypican-3. I have experience with only Glypican-3. And when it works well, it should stain the membranes very nicely like this. Couple of caveats to remember. Unfortunately, there's always a caveat with these stains, right? You can't just take them for their word. Some high-grade dysplastic hepatocellular nodules are positive, but that doesn't make a huge difference. If you call a high-grade dysplastic hepatocellular carcinoma, no one's going to fault you for that. I think the bigger problem is that a significant proportion of very well-differentiated HCCs are negative. So when you're really counting on it, it turns out to be negative. So, all right, so here's your test, right? So you've heard that. Hopefully you've been paying attention. So now let's see if you can work this out. And I can tell you what I did. So this was an 84-year-old guy with a 14-centimeter mass. Here's the biopsy. Unfortunately, there was no normal to work with, right? It was all lesional tissue, so no portal tracts. I look at this. This looks somewhat crowded, doesn't it? But I have nothing normal to compare with, so that becomes somewhat of a problem. I'm counting the thickness of the plates, maybe 3, maybe 4. You know, wasn't thick enough for me to call it outright HCC. And I'm looking down at the slide, and I remember this was on a Friday, and I was desperate to get out of town. It looks cellular. The monotony is sort of getting to me. There's the pseudoglandular pattern that makes me even more worried. I was counting on the Glypican-3, and unfortunately, this is all it showed. This is pathetic, you know. You cannot really call it HCC based on that staining there. But there's another stain that I did not introduce you to, and that is glutamine synthetase. This tumor was diffusely positive for glutamine synthetase. Now, before you get excited, now this is a marker of HCC, but before you get excited, all excited about it, remember hepatic adenomas are also positive for glutamine synthetase, so beware. Here's the reticulin stain. So I'll let you guys decide whether it's lost or not. I can tell you what I thought it was. I thought there was some loss, but it isn't striking loss, right? So what we ended up with all these subtle features of hepatocellular carcinoma. It smells of hepatocellular carcinoma, but the thing that actually ended up helping me the most was the age of this patient. Remember, this was a large mass in an 84-year-old male. 84-year-old male patients do not get HCCs. And so then I used my glutamine synthetase in that context and used that to call this a very well-differentiated HCC. Now, this patient did not have cirrhosis, but if you did have cirrhosis, that would be helpful as well. All right, so what if you were uncomfortable about calling this an HCC? You should feel free to call this a well-differentiated hepatocellular neoplasm. This is what I put on my top line. There is no shame in telling a clinician, look, this is very well-differentiated. I simply cannot tell benign from malignant, and I've certainly done that. All right, so question 3, this should be quick. Now we're moving to the other end of the spectrum. Take a look at this. This is what I'm talking about. You look down the microscope and you see something like this. Lots of cytoplasm, yes, but are you absolutely certain that this is an HCC? Are you certain that this is an HCC? It probably is, but wouldn't you like to confirm it on an immunohistochemical stain? So that's the cheat sheet that I carry at the top of my head. I'm not expecting you to read this, but this is this table is from one of the reviews I wrote many years ago, but I think it was in the archives of pathology and lab medicine. The good old golden oldie is alpha fetoprotein. In my hands, it's almost never ever helped me, so I'm not going to talk about it. Hepar1 used to be the new kid on the block many, many years ago. This is a nice reactivity for Hepar1, strong granular reactivity. This was indeed a hepatocellular carcinoma. But there's lots of caveats with Hepar1. One is it is not sensitive. It's not specific enough. But even more importantly, it does not work. Think of this. It does not work when you need it the most. You need it at the poorly differentiated end of the spectrum, and it seldom works at that end of the spectrum. The same problem applies to polyclonal CEA and CD10, both of which show this killer pattern, this antler horn-like pattern. But unfortunately, it does not work at the poorly differentiated end of the spectrum. So what's the stain we rely on? We rely on arginase. It is more than 95% specific and 95% sensitive for hepatocellular carcinoma. So it is our best bet currently for a diagnosis of HCC. What about this case? You remember this image I just showed you? It probably is an HCC, but I want some icing on the cake to call it, right? Outright. Arginase was negative, Hepar1 was negative, and it turns out that the albumin in situ hybridizations, this is something that you can do if you have one of these automated instruments. The albumin in situ hybridization was diffusely and strongly positive. In our hands, albumin in situ hybridization is more sensitive than arginase. So when I have an arginase negative HCC, I'll get an albumin. But we'll talk more about albumin in a minute. All right, so number 4, we're doing well for time. So this gets at the 2019 classification. Now we're switching to cholangiocarcinomas, and we're going to talk about the 2019 classification of cholangiocarcinomas. That's the so-called blue book, right? So think back, right? How do you classify cholangiocarcinomas? Intrahepatic, extrahepatic. That's an anatomic-based system. So we're not really contributing very much. This was really a radiology call, right, for the most part. The 2019 classification has significant changes. And we now classify cholangiocarcinomas into small duct and large duct, which if you think of it, we've moved from an anatomic-based classification to a histology-based classification. And even more importantly, there is a genetic element that I'll touch upon in a second. So let's look at what this classic gross of a small duct. I love great gross photographs. So if any of you guys follow me on Twitter, you'll probably see a few every month. There's nothing like a well-taken gross image. It tells such a story. It tells a story that no slide could ever tell. So this is what a classic small duct cholangiocarcinoma looks like. They tend to be peripheral, but not always, and they tend to be very well circumscribed. The large duct tend to be hilar, perihilar, and they tend to be rather infiltrative, as this example shows. So let's look at a few examples of a small duct HCC. This is a classic small duct HCC. Makes sense, right? It's composed of relatively small ducts. There's the lumen. You know, cholangiocarcinomas in general tend to have these very monotonous nuclei, particularly the well and moderately differentiated cholangios, and they tend to have a very prominent desmoplastic stromal reaction. So this is a classic small duct type cholangiocarcinoma. The one thing I will emphasize, and I can't emphasize this enough, they do not have pools of extracellular mucin. So extracellular mucin is not seen. But there's clearly a spectrum. If you look at cholangiocarcinomas, you'll immediately notice the spectrum. This pattern. I pulled this out specifically. It's not a common pattern, but this is a cribriform pattern of cholangiocarcinoma. And you might wonder, I wonder if this is something from the breast. And then you can have these small duct cholangiocarcinomas without really any tubules. Instead, there is this abundant eosinophilic cytoplasm, not to be mistaken for HCC. I know many of you are thinking HCC. This is not an HCC. Here's another variant, and I pull this out specifically because this is something that, colloquially we refer to as the ischemic type pattern. Look how banal these cells are. This is a cholangiocarcinoma, but as you can imagine, it's so easy to think something benign in this case. Believe me, this is a intrahepatic cholangiocarcinoma. All right, so that was all small duct. So now the large duct. So large duct is composed of large ducts, obviously. But I think even more importantly, large duct cholangio is associated with a lot of mucin. And if you step back for a second and think about this, large duct cancers really look like pancreatic adenocarcinoma. And genetically, they actually resemble pancreatic ductal adenocarcinoma. So I'm going to leave this table for you to admire. But I think the most important distinction between the two types I want to emphasize, and for a very specific reason, is that the genetics are very different. And both of these genetic alterations, IDH1-2 mutations and FGFR2 fusions, have targetable FDA-approved drugs available now as of this year, right? So this is why you need to make the appropriate diagnosis of cholangiocarcinoma and subclassify it, because then they can get appropriate sequencing and potentially targeted therapy. So the world of cholangiocarcinoma is changing very, very fast because of these new FDA-approved drugs. But unfortunately, the classification system is not perfect. So here's a hilar tumor, right? This is in the hilum. You can see all that fat, these big fat vessels. But is this small duct or large duct type? It's certainly made up of large ducts, right? Some of these are really large. But like I said, there's no mucin. So is this small duct or is this large duct? And it turned out to have genetics of a small duct. So not all cases easily fit into this classification. I call this classification imperfect, but it's a significant advance over what we had before, because we moved from an anatomic-based classification to a morphologic genetic classification, which is a huge move. All right, so remember the albumin stain? Well, this particular tumor was diffusely positive for albumin. We'll come to that in a minute, so hold your thoughts. Because question number 5, and I think this is a really important one. The question is, when you look down the microscope, you see a biopsy from the liver. It looks like an adenocarcinoma. The question is it primary or met? Remember, mets are far more common than cholangiomas by probably 100 to 1. So statistics are against you when you're calling something a cholangiocarcinoma. And as I just told you, this distinction is more important than ever before because of those targeted therapies. All right, so put your thinking hats on, stare down at this image. 52-year-old, 3 dominant nodules. Here's the biopsy, and I'm going to ask you, take a look at this, and I'm going to ask you to make a diagnosis. Right? So is this a cholangiocarcinoma or is this a metastatic adenocarcinoma? And to do that, I think you do need to know what cholangiocarcinomas look like. I gave you a brief review, but here are a couple of more. So this is the classic small duct type pattern. This is what I refer to as the sort of the nested pattern, which looks sort of neuroendocrine. Believe me, it's not neuroendocrine. And then some cholangios can get pretty undifferentiated and spindled, and these are really problematic. Fortunately, at least a third of cholangios look like this. This is what I refer to as the cholangiolar pattern. And when you see this pattern, that is very suggestive of a cholangiocarcinoma. Here's how I best describe the pattern. I'm just going to draw these lines through the lumens, right? That's the pattern that emerges, right? Doesn't that pattern look like this? In fact, if I flip it over, actually this part of those antler horns look exactly like that. when you see this antler horn-like branching pattern in a liver tumor, think cholangiocarcinoma. It's not 100% sensitive, it's not 100% specific, but it's highly, highly suggestive of a cholangiocarcinoma. So the other patterns are relatively nonspecific, but the cholangiolar pattern, if there's one thing I want you to remember at this end of this talk, is that the cholangiolar pattern is very suggestive of cholangiocarcinoma. So what about this tumor that I just showed you? I agree that the lumens are not very clear, but they, believe me, they're there, and I'm just tracing out the outlines of these cells. Now, don't you think that looks sort of like antler horns? That's cholangiolar pattern, and I'd sign that out as very suggestive of intrahepatic cholangiocarcinoma. But what about this tumor? Is this primary or is this met? And that's where things get difficult, right? And we use immunohistochemistry, as we all do. But in my opinion, it's not, immunohistochemistry is not particularly helpful. The keratin 720 profiles, unless it's a colon, is quite unhelpful. The reason I've hidden away the TTF1 here is because I want to remind you that almost a third of large duct cholangios are positive for TTF1 and napsin, right? And that could really throw you off the scent. And even more troublesome is the fact that some of these commonly used markers, and this came as a surprise to me, some of these commonly used markers are positive in cholangiocarcinoma. Oh, apologies. And so you've got to be very careful when interpreting immunohistochemistry with the cholangiocarcinoma. I'm sorry about that. I'll take that call later. So back to our albumin in situ hybridization. It turns out, at least in our hands, that albumin in situ hybridization is the best possible marker we have today to distinguish a cholangiocarcinoma from a hepatocellular carcinoma. I don't expect you to read this, but if you photograph this you could take that to the bank. But that, I'm going to be covering all of this. Rather, we are going to be covering all of this. We're writing a review with Monica Vyas from the BI, and the issue is out into 2022, so you'll find all of these tables there as well. It turns out that almost every intrahepatic tumor is positive for albumin. Most metastatic adenocarcinomas are negative for albumin. The bottom line is, if we see a positive albumin stain, we call it as very suggestive of cholangiocarcinoma. So here it is. Here's that tumor that I showed you. You can see it's strongly positive for albumin, and I'd call this very suggestive of a cholangiocarcinoma. So the couple of things I want you to remember from this talk. One, don't use an extended immunohistochemical panel. It does not help. Just a very limited panel is good. If you have albumin, that's great. If you don't have albumin, look for that cholangiolar morphology. And the last thing I'll say, and I can't emphasize this enough, make sure you save enough tissue for molecular studies, and remember those 2 targeted therapies for cholangiocarcinoma. So I've got a couple of minutes, and I'll just do this very quickly. This is an interesting part of the talk, because this is where you get most embarrassed, right? So you're looking at something like this, right? And you're telling yourself, these certainly look like hepatocytes. These certainly look like hepatocytes. Is this hepatocellular carcinoma? Anyone? Anyone? Hepatocellular carcinoma? That was the stain that was positive. It's HMB45 positive. This is an angiomyolipoma or a pecoma. Pecomas are very much like HCCs. Here's another. CD31. This is an epithelioid hemangioendothelioma. Again, easily mistaken for an HCC. What do you guys think of this? This is not an HCC. This is a metastatic lobular carcinoma. And finally, I love this example. So this, I can tell you, has sinusoidal wrapping, right? The cells look like hepatocytes, but this is not a hepatocellular carcinoma. This is an adrenal cortical carcinoma. It's going to look very much morphologically like hepatocellular carcinomas. Now, if you do the right immunohistochemistry, you wouldn't have a problem. But without immunohistochemistry, just on an H&E, you might go down the tubes. And finally, this is my finest example. And believe me, I've done this and fallen into this trap. The cells have abundant eosinophilic cytoplasm, right? And you're wondering, and this was a biopsy from the liver. And I was imagining this endothelial wrapping here, and perhaps there's an endothelial cell there, but this is not an HCC. And this, embarrassingly enough, turned out to be a metastatic pancreatic endocrine tumor. That was the chromogranin stain. But remember, the stain is not positive until you actually perform it, right? So some mimics of HCC that could really come back and embarrass you, and that was the last case. And finally, as Dr. Keeney mentioned, I'm very avid on social media, and so follow me if you wish. I also have a YouTube channel with some videos posted there. So thanks again, guys, and I'm happy to take questions.